Cardiac muscle dysfunction or heart failure is the most serious progression of problems affecting the heart and is a matter of great challenge for management. In this presentation, we will review what it is, how it sets in, what are the types, what is the progression, and what are the ultimate in prognosis of heart failure. We will review the available medical therapies, including pharmacologic and surgical. We will briefly discuss the effects, side effects, and limitations of drug therapy. This video has the major chapters hyperlinked in the description below for quick navigation to major elements of heart failure. I encourage you to pay very deep attention to pathophysiology as it gives you the foundation to how you evaluate your patient for inclusion or exclusion in cardiac rehab program options. One word of caution here is that not every patient is appropriate for rehabilitation. Hence, patient selection is vitally important regardless of referral, and it is the physical therapist's responsibility to make that decision. Let's get started. These objectives outline the information we will cover in this presentation. Please pause the video and take a moment to review and reflect on these objectives. The summary slides in your version of the PowerPoint encapsulates each individual area as a separate or major section. Let us now look at heart failure as a condition. Cardiac muscle dysfunction is a term that has gained popularity in describing an apparently common finding in patients with heart and lung disease. Cardiac muscle dysfunction effectively yet very simply describes the most common causes of congestive heart failure. The condition is very common and indeed increasingly common these days due to the The fact that they are a common complication of underlying heart disorders of the elderly and the older population, increasing not only throughout North America but also worldwide. Heart failure develops as a result of some underlying abnormality of cardiac structure or function. Those presenting only with cardiac muscle dysfunction, that is, who are at risk of heart failure, may present without symptoms. As the abnormality progresses, the heart begins to fail to function effectively to meet the demands of the body, and the heart failure symptoms begin. The syndrome of heart failure is accompanied by symptoms of shortness of breath and fatigue at rest or with activity. So, how do we define heart failure? Heart failure is a condition that is defined differently by different cardiology experts depending on the mechanisms that lead to or the symptoms that develop in a patient with heart failure. However, at the very basic, heart failure is a syndrome with a variety of interrelated pathophysiologic phenomena where impaired ventricular function is the most important. Heart failure can also be defined as a pathophysiologic state where the heart fails to pump blood at a rate commensurate with the requirements of the metabolizing tissues or is able to do so only with an elevated diastolic filling pressure. In simple terms, if someone needs to do any basic movement or exercise, they need to increase their blood flow to those body parts, not just the muscle, but um, any metabolizing tissue. And if the heart cannot ramp it up to meet that demand, then it would be called heart failure. We will address the meaning of the phrase elevated diastolic filling pressure in the next slide. So, what is an elevated diastolic filling pressure? To explain that phrase, let's look at the function of the left ventricle. The left ventricle must overcome the systemic vascular resistance, or otherwise called the total peripheral resistance of the arteries to pump blood into the systemic circulation. In case of an increased resistance for whatever cause, the left ventricle will have to work harder to eject the same amount of blood. Over time, muscle adaptation will lead to ventricular walls becoming hypertrophied, thus increasingly stiff. The wall becoming thicker will lead to reduction of the chamber size and chamber space. Together with increasing stiffness, this will allow less filling of the ventricle from the atria above during the diastolic phase. Thus, there will be less blood coming into the chamber, thereby, there will be a reduction of the amount of blood that can be ejected per cycle, and this will reduce the cardiac output, which is the hallmark of heart failure. As we will see, there are a number of compensatory mechanisms triggered by heart failure, where some of these mechanisms actually cause or compound the symptoms of heart failure. The major issue is that the cardiac output is going to be reduced. Recall from physiology that cardiac output is the stroke volume, which is the amount of blood ejected per beat, multiplied by the heart rate. In effect, the body feels as if it can solve the problem by increasing the blood volume. It does so by various compensatory mechanisms that restrict water loss and thereby gain more water that it pulls into the vascular system, hoping to correct the heart failure state. Unfortunately, this leads to fluid accumulation in the body such that water may escape the vasculature and fill the tissue spaces with fluid, thus contributing to edema or what we call swelling of dependent body parts. It also leads to circulatory congestion, for example, in the lungs, where there is increased fluid that escapes from the blood vessels into the lung spaces. There are approximately more than 3 million patients in the United States. A significant number of patients are diagnosed new every year, and the prevalence rate is approximately 1 to 2%. Unfortunately, the prognosis of heart failure is grim. It is a relentless disease where the ultimate prognosis, while dependent on a number of factors, will eventually result in premature death. In those terms, the prognosis is just about as grim as a number of forms of cancers. Heart failure is the leading cause of hospital readmissions worldwide. Approximately 30 to 40% of patients with heart failure are hospitalized each year and uh, leave their mark on the costs associated with this disorder. Heart failure is the leading diagnosis among hospitalized patients more than 65 years old. 35% of these patients will be dead within 1 year of diagnosis. The condition is more common in African Americans and non American blacks. Interestingly, people of color, especially blacks, tend to be somewhat better in hospital admission outcomes in comparison with their white counterparts. But the long term outlook in the African American population is considerably worse, likely in those with lower socioeconomic conditions. Women are less frequently affected by heart failure than men early on, but once the population reaches 65 to 70 years of age, no sex predilection exists to the extent we see for now. When we discuss heart failure, we talk of certain factors that influence heart failure. You may recall these factors from basic cardiac physiology. Recall the terms preload. Preload is the filling volume of the heart. It directly influences the size of the ventricles, thereby the stretch on the ventricular wall when it is full of blood. More blood returning to the heart, greater the fill, thereby greater amount of stretch on the ventricular wall. Also recall from basic muscle physiology that pre-stretching muscle fibers before a forceful contraction results in an increased force of contraction. Greater the pre-stretch, more stronger the muscle contraction. The same principle can be applied to the heart, and thus more preload equates to a greater ventricular contraction. Thus, greater cardiac output occurs in the healthy heart. This same mechanism happens with some of the compensatory mechanisms in heart failure, which increase the blood volume in an effort to increase the preload. This leads to increased filling pressure in the ventricles during diastole. These increase also recall from cardiac physiology the term afterload. Afterload is the work of the heart when it is pumping out. In pumping out, the left ventricular muscle has to overcome the resistance in the systemic vascular system, also called the total peripheral resistance. Chronic disease, for example, hypertension, causes increased total peripheral resistance, which will lead to an increase in afterload which you can imagine is not good for the already failing heart. This should give you a clinical clue in that one of the targets of heart failure management is to decrease afterload, thus to reduce the work of the heart to allow it to recover, if feasible, from the depressed state. There are numerous videos available which explain heart failure in some or extensive detail. This is one of them. Use it as you may wish. A link is provided as well. Heart failure is a complex syndrome, but regardless, it has very defined fundamentals. Heart failure is not a disease. Instead, it is a syndrome in that it is a collection of disorders that prevent the heart from doing its primary obligations in the body. Therapeutics in heart failure require the understanding of the mechanisms that lead to the signs and symptoms of the disorder and its progression. Primary prevention of these underlying mechanisms prevent the progression of the disorder. Secondary prevention is where the effects of the established and diagnosed disorder is managed, which is where a bulk of physical therapy interventions are directed at. Let's take a deeper dive into the classification of heart failure and how it informs us the underlying cause, prognosis, and treatment options in heart failure. As I alluded to you earlier, there are many ways to classify heart failure, and different specialists not only look at individual patient specific problem with a different lens, but also use a classification system that best describes the patient problems. In any case, what you need to remember is that while the terminologies used in the classification of heart failure is different depending on the specialist and the patient's symptom sets, it is the same underlying disease, but the terminology gives you the smoking clue to what the patient's underlying problems most likely are. On this slide, you will see all the different terminologies that are used to describe heart failure. Um, these terminologies are mostly hyperlinked on this slide for you to uh, do additional reading if this lecture itself is not clear. But I'll attempt to explain these terminologies in the ensuing slides. Heart failure has traditionally been seen as side based, either left side or right sided heart failure. This anatomical distinction assumes that each side of the heart supports two distinctly different circulations and hence two different set of symptoms to deal with when each side is involved. While each sided heart failure has distinct symptoms, it is usually always a mixed finding in post mortem autopsies, which tells us that distinctly separate sided failure is perhaps not true. In other words, there are elements of both side dysfunction in patients with diagnosis of heart failure. When both sides are clearly involved, it is called biventricular heart failure. Regardless of whether it is left heart failure or right heart failure in clinical settings, postmortem studies therefore usually support the presence of biventricular failure. In left-sided heart failure, there is reduced systemic cardiac output and elevated pulmonary and venous pressures due to backflow into the lungs. When there is The cardinal signs of right heart failure can be extrapolated to symmetrical dependent edema, hepatomegaly, jugular venous distension, and central and eventually peripheral cyanosis. Weight gain from fluid retention is a common finding, usually rapidly escalating weight within days to weeks. In fact, the most important reason for rapid weight gain is fluid retention from right heart failure. Other non-cardinal features may include splenomegaly, anorexia, and nausea. The video can be used for further clarification. The cardinal features of left heart failure include dyspnea, orthopnea, and paroxysmal nocturnal dyspnea. Dyspnea is, of course, shortness of breath. Orthopnea refers to shortness of breath while laying flat. Orthopnea can be classified in grade severity by the unit of quote unquote pillows. The number of pillows to prop up the head to allow the patient to breathe comfortably is the degree of orthopnea. So we can ask patients as to the number of pillows it takes to make them comfortable. For example, 2 pillow orthopnea, 3 pillow orthopnea, and so on. Paroxysmal nocturnal dyspnea is the unscheduled, sudden waking up at night due to inability to breathe. The word paroxysmal means sudden. Additional to the cardinal symptoms of left heart failure, we can also expect pulmonary crackles, a sound which we hear by a stethoscope, and hacking cough, along with compensatory tachycardia, fatigue, and muscle weakness. The video may help you with your concepts more granularly, uh, as I have provided. Oftentimes, congestive heart failure is strictly discussed in terms of left ventricular dysfunction. In context of left ventricular dysfunction, there are two types of heart failure: systolic heart failure and diastolic heart failure. In very brief, systolic dysfunction is where the heart cannot pump well, and in diastolic dysfunction, the heart cannot fill well. Let's take a deeper dive into this classification. Let's consider diastolic dysfunction of the left ventricle first. In this condition, the ejection fraction is preserved, and thus this is also called heart failure with preserved ejection fraction, or HFpEF. In this condition, there is chamber hypertrophy and concentric remodeling of the myocardial fibers such that the ventricular walls become extremely thick. In concentric remodeling, the ventricular fibers thicken the wall of the ventricle, therefore causes chamber hypertrophy. As a result, the actual open space or volume within that chamber decreases because there is increasing muscle mass. While the ventricles feel all right, it fails to relax normally. This leads to increased pressures in the ventricle, which is then transmitted throughout the circulation, leading to collection of fluid in the tissues, referred to as edema. And we have discussed this before. Filling of either ventricles is impaired because of excessive hypertrophy or changes in the composition of the myocardium. Systolic dysfunction, on the other hand, is the inability to squeeze adequately for ejecting the blood and can be caused by impairment of any of the factors of preload, afterload, contractility, or chronotropy, either individually or in combination. As shown before, approximately two-thirds of all heart failure patients will have systolic dysfunction, making this by far the largest group of heart failure patients, as just discussed earlier. This, of course, is the result of numerous underlying pathologies, such as those who have had a heart attack, otherwise called myocardial infarctions, those who have had underlying cardiomyopathy, which is an intrinsic disorder of the heart muscle itself, and often systolic heart failure is also associated with diastolic dysfunction, similar to how we saw left heart failure coexisting with right heart failure. While the medical management is complex or as complex as the disease itself, one of the options in medical treatment of systolic heart. In some cases, you will see the terminology of heart failure classification as forward heart failure versus backward heart failure. This terminology is not commonly used clinically anymore, but it actually indicates the direction of the problem. In forward heart failure, the heart is unable to pump out adequate blood. That means it's a ventricular functional impairment, and thus the blood is not being pumped out. So you can compare that with systolic dysfunction. Backward heart failure is where either ventricles fail to pump its full load of blood. So the blood return or comes into the ventricles fill up with blood, but they are unable to uh, pump all of it out, which leads to backup into the lungs and the body. This backup is what leads to the various kinds of systemic edema or swelling and pulmonary edema. Together, these backward flows is what is referred to as back. We also see terminology of low output heart failure versus high output heart failure. In high output heart failure, the cardiac output remains normal at rest, um, uh, or it may even be higher than normal. However, the demand for blood flow is abnormally high, and the heart is unable to meet the demand. Uh, Such kind of high output heart failure is seen in certain disorders like hyperthyroidism, beriberi, severe anemia, arteriovenous shunting, osteitis deformans, which is in orthopedics we commonly know it as Paget's disease, and in certain sepsis conditions. On the flip side, low output failure is where the cardiac output is low. It is pathologically low, and the demand, on the other hand, may be normal. So, So these are terminologies to explain the phenomena that I just told you. Again, high output and low output. The classification of heart failure up to this point focused on the clinical pathological uh, state of heart failure. However, none of those heart failure classifications allude to the functional ability of the patient. Therefore, the advent of the New York Heart Association classification of heart failure, which was based on severity of patient symptoms and activity limitations. On this slide, on the left-sided image, you will see the classic NYHA classification of functional heart failure. This classification is based on 1 through 4, and the associated descriptors are provided. Along with that, the METS level is also shown. So class 1 New York Heart Association grading is where the patient has no limitations of function and ordinary activity will not cause the symptoms of heart failure. Such patients are able. Finally, in this section of classification of heart failure, we should have a discussion on compensated versus decompensated heart failure. In fact, this is not a classification of heart failure, but an important set of terminologies to master. Heart failure is one of those conditions that periodically worsens with increase of symptoms. This periodic worsening is called an exacerbation for any such disease, including heart failure. Thus, the phrase, quote, exacerbation of heart failure, close quote. Generally, a diagnosed patient of heart failure is controlled on various therapies. A patient who is in controlled state does not exhibit symptoms or signs of the disease, even though the disease may exist as diagnosed. Thus, patient is not short of breath or swollen or does not demonstrate other features of heart failure because their symptoms and thereby the disease is controlled and the patient can go about their daily lives. It is typical for physical therapists and cardiac. Also relevant to the discussion of pathophysiology of heart failure is the condition called Cor Pulmonale. Cor Pulmonale refers to failure of the right side of the heart, secondary to underlying pulmonary disease. These pulmonary diseases can be many, for example, COPD or idiopathic pulmonary arterial hypertension, problems with the upper airways, such as untreated obstructive sleep apnea, and chest wall deformities such as kyphoscoliosis. Um, Right-sided heart disease due to or concurrent with left-sided heart disease or congenital heart disease is not considered cor pulmonale. So cor pulmonale is only when there is right heart failure secondary to underlying lung disease. And this is a very important demarcation from other heart failures. It is important to remember that cor pulmonale is associated with lung disease, and a more detailed discussion is. Let's now look at some of the causes of heart failure. The overall factors that contribute to heart failure are listed here and shown in the graphic. If any of these circumstances occur, then there will be eventual heart failure. Let's take a few examples. Number one, let's take the example of reduced myocardial contractility. If there is a progressive loss of strength of the myocardium due to things such as chronic ischemia or a sudden loss of muscle strength due to death of the muscle induced by myocardial infarction, then there will be a loss of ability to pump, and that is contributory to CHF. Similarly, if there is a lot of increased peripheral resistance from the aorta, so if there is a significantly raised hypertension, then that will contribute to heart failure. And by that measure, each one of these others will be contributory to heart failure. So there are so many ways by which the heart can fail. The eventual result, however, is clear. Now, the causes of heart failure can be broadly divided into two categories just for memory's sake. They can be extrinsic causes or intrinsic causes. Let's look at the extrinsic causes. These causes are things that happen to the heart not directly, but because of whatever is happening outside the heart or the myocardium, indirectly affecting the myocardium. Intrinsic diseases of the heart, uh, of the heart muscle, on the other hand, can also cause heart failure. Let's look at each one of them. So the extrinsic disorders, as you can see here, are conditions that we have discussed before in the causes categories, but you will see that each one of this is not necessarily something happening directly with the heart. For example, hypertension. It is a vascular problem, but it increases total peripheral resistance and affects the heart. Similarly, ischemic disease, even though ischemia is happening in the heart itself, but you have to remember it is a vascular problem. And this vascular problem is indirectly going to affect the muscle. And you can take that analogy into any of these other conditions, and you will see that these are not something happening within the heart, but eventually weakens the heart. And that is the crux of this particular discussion. On the flip side of the extrinsic causes of heart failure, we also have a group of disorders where the disease is intrinsic to the heart muscle. These disorders are collectively called cardiomyopathy. In cardiomyopathy, the pathology is of the muscle cell of the heart itself. The condition can be classified by presentation, pathophysiology, and the type of abnormality of the muscle cell. We see three of these cardiomyopathies shown in the picture to the right. We have dilated cardiomyopathy, which is often a sign of systolic dysfunction, where the heart has too much of blood in it and it dilates. On the other hand, we see hypertrophic cardiomyopathy, which is seen in diastolic dysfunction or contributes to diastolic dysfunction and is shown in the middle. And we also have restrictive cardiomyopathies where there is usually a blockage to the outflow tracts of the ventricles, usually the aortic valve and the pulmonic valves. Now, we have alluded to numerous compensatory mechanisms that come into play as the body tries to overcome a falling cardiac output and a falling ejection fraction. These compensatory mechanisms are discussed further in this section. As stated, once heart failure begins, the body attempts via various compensatory mechanisms to try to account for the falling cardiac output of the heart. The bigger question is as to why does the body set off these compensatory mechanisms, some of which are listed on this page. So, why does the body need to compensate for decreased cardiac output or decreased pumping of the blood? The answer to that is that when the cardiac output starts to fall, the body interprets it as a loss of blood volume, such as that can occur with bleeding or dehydration. Maybe the person is actually bleeding or losing blood somewhere, or they are dehydrated, both of which will reduce blood volume. Thus, the body's mechanisms get kick-started by triggering a whole lot of neurohormonal mechanisms to try to build up the blood volume by holding on to water and salt instead of losing them through. Let's look briefly at the diagnostics involved in heart failure. Heart failure has no one uh, bulletproof diagnostic test. It is a combination of various parameters that are examined via laboratory exams, chest x rays, ultrasound, ECGs, nuclear medicine tests, and so on to uh, confirm the presence of and the progression of heart failure. All these tests listed on this screen are lab parameters that are reviewed for congestive heart failure because of its propensity not only to show what is wrong with the heart but also the impact it is having on other organ systems. The most clinically relevant parameter in modern clinical practice to evaluate the degree and presence of heart failure is BNP and NT-proBNP. BNP or brain natriuretic peptide is secreted by the ventricular myocardium in response to the stretching of cardiomyocytes because of overfilling. BNP has a vasodilative, diuretic, and natriuretic activity and is a sensitive marker of left ventricular end diastolic pressure. ProBNP, on the other hand, is the precursor of BNP, which is enzymatically cleaved into an inactive amino terminal fragment known as NT-pro. For purpose of this course as well as the boards, I would encourage you to review and remember the lab values of the common parameters that we look for in heart failure. Of these, B-type natriuretic peptide or BNP has a normal value of less than 100 picograms per milliliter. Please note the unit. If you mark it as milligram per ml, then it would be wrong. Um, the interpretation of BNP is that if it is below 100 picograms per ml, then it is normal. If it is between 100 and 300 picograms per milliliter, then heart failure is present. And then 300 to 599 picograms per milliliter is mild heart failure. More than 600 picograms per milliliter is moderate heart failure, and more than 900 picograms per milliliter is severe heart failure. It is also an important demarker. Let's now look at some chest x-rays in heart failure. This schematic tells you the parameters we'll look for in a chest X-ray. We'll look at the uh, horizontal diameter of the chest, which shows the cardiac silhouette, the costophrenic angles, which is these are the costophrenic angles. This is the horizontal diameter, which obviously in this picture is significantly enlarged. The presence of curly lines, which are shown here. There are several types of curly lines, curly A lines, curly B lines, um, and so on. However, these lines are indeed called curly lines, and these are a feature of heart failure. In left heart failure, backward flow from the left atrium engorges the blood vessels, and that is what causes these engorged blood vessels to show in the X-ray. This engorgement is what we call pulmonary edema. And in addition to these engorged blood vessels, we see this is an example of severe um, heart failure. You notice how there is an increased cardiothoracic ratio with very wide, uh, extremely widened base of the chest, and the relative widening of the cardiac silhouette at the base. You see the presence of fluid in the pleura, which is shown as pleural effusion, this white streaking, and then this is pulmonary vascular congestion. Uh, these pulmonary vascular congestion is showing up as white in this area. We mentioned curly lines earlier. These specific lines seen here, these are the curly B lines. As I mentioned, there are other types of curly lines, and these lines are indicative of heart failure, curly B lines. Um, Additional factors will be seen in other X-rays. So this is a typical chest X-ray in a heart failure patient. Typically note these aberrations. First of all, the costophrenic angle, which is this angle, should be smooth and very sharp angle. This angle, which is shown here, should be sharp and black, and in this case you see how it is whitened. Again, in this case, the costophrenic angle, which dips right down there, should be nice and sharp. Instead, what you're seeing here is this fluid level. This fluid level indicates that there is water that has escaped into the pleural cavity. That is um, this fluid level shown right here is an indication that there is water in the pleural cavity. Now, that itself doesn't tell us the person has heart failure. That would be related to the history and other presenting problems, because pleural effusion can happen in cancer. It can happen from other conditions as well, but the fact that there are supporting evidence. There is some more information about curly lines in the links provided here, and also about septal markings in the lungs. You should read these on your own, as these web pages have good quality images associated with the descriptions. More examples of heart failure in this slide. On the left-sided image shown here, uh, here, this is a normal image. This is a normal image. This is how a normal X-ray should look like. If you notice, again, one more time, you see the defined knuckle of the aorta here, and then you see this is the normal width of the heart. Now, since this image does not have the full lateral margins of the chest, it does not show you the entire cardiothoracic ratio, but this is a normal appearance of the heart. Uh, on the other hand, if you look at the image to the right, you notice this pulmonary vasculature markings being much more enhanced, or sorry, whitish, and these uh, indicate the presence of fluid congestion in the vasculature, as well as as well as um, further X-ray discussion and examples of heart failure can be seen at these links. This slide shows you an ultrasound in heart failure. This is beyond the scope of discussion in this particular presentation. Cardiac nuclear medicine is useful in diagnosing and assessing coronary artery disease uh, primarily. It is also used to evaluate cardiomyopathy and identify possible damage to the heart from chemotherapy or radiotherapy. Nuclear medicine imaging procedures are non invasive. With the exception of intravenous injection, they are usually painless. These tests use radioactive materials called radiopharmaceuticals or radiotracers to aid in the diagnosis. Let's now look at the pharmacologic management of heart failure. There are three major goals of drug management of the failing heart. Uh, Number one is to slow the progression of the disease. Number two is to improve symptoms. And number three is to prolong survival of an otherwise relentless disease. The conceptual goal of pharmacologic management of congestive heart failure is to influence cardiac output or increase cardiac output by influencing all of the listed elements that includes uh, managing preload, managing afterload, and managing contractility. If you look back at the pathophysiology of heart failure, this means the drug therapy would aim to reduce preload, reduce afterload, and increase contractility of the heart. The major drug classes of management of heart failure are listed here. Diuretics reduce the blood volume by reducing the water content of the body and uh, uh, thereby reducing the load on the heart. Vasodilators reduce both preload and afterload. The drug digoxin produces small increases in cardiac output by being an inotropic by influencing inotropic function. Direct inotropic agents restore organ perfusion and reduce congestion in the vasculature. Beta blockers modify neurohormonal processes, improve left ventricular ejection fraction, prevent arrhythmias, and controls the ventricular rate. ACE inhibitors and angiotensin receptor blockers, or ARBs, also provide neurohormonal modification, vasodilatation, and overall left ventricular ejection function. So, based on goals of pharmacologic management, here are the major drug classes. So the management of heart failure using drugs is really complex. It is as much of an art as it is a science. There is no predetermined ratio of drugs that are used or that can be used to manage the features of heart failure. It is a trial and error over a period of time in every single patient to determine what works best for that person. These parameters cannot be um, written in stone because every person reacts to medications differently. Many drug classes are involved in the management, as we just saw. The patient needs close surveillance and very fine titration of the medications to ensure that the optimal function and functional benefit is obtained. Some of the drugs within the classes discussed are reserved for emergency and critical care situations. And finally, it is important to note that these drugs have significant side effects. The concerns in the drug category or drug management of heart failure primarily is based on the drug class that is used. Each drug class has its own side effects. Drugs that decrease the cardiac workload by reducing preload are the ACE inhibitors, the ACE2 receptor blockers, the beta adrenergic blockers, diuretics, and vasodilators. Their mechanism of action is noted in this table. Diuretics reduce blood volume. Please see antihypertensive role of diuretics for details on these drugs. The drugs that reduce afterload are vasodilators, which increase the arterial diameter and reduces resistance to flow. Some vasodilators increase both arterial as well as venous diameter. ACE inhibitors and ARBs reduce peripheral vascular resistance directly. A combination drug which has become available more recently is sacubitril and valsartan combination, which is called Entresto on the market, and it's approved by FDA in 2015. It increases ejection fraction by reducing afterload, and there are some more details on this drug on the antihypertensive pharmacology presentation. Vasodilators um, are also discussed in the ischemic heart disease pharmacology, but the principal ones are hydralazine and the entire nitrate group of drugs and others. The pharmacology of ACE inhibitors are also discussed in antihypertensive pharmacology, as also the ARBs. Now, the primary drug class that increases the force of contraction of the heart, which is the primary objective, is to increase the heart's contractility, are the inotropes. Inotropes, or in other words, inotropes are also positive inotropes, are drugs or agents that increase the force of contraction of the cardiac myocyte. The first group of drugs are called cardiac glycosides, which is derived from digitalis, which is a plant product. The two drugs derived from digitalis are digoxin and digitoxin. These increase the ejection fraction by directly increasing calcium influx into the cell and increasing the force of contraction. The other positive inotropes include the drug class phosphodiesterase inhibitors. Under phosphodiesterase inhibitors, we have the bipyridine class, which includes other positive inotropes include sympathomimetic drugs, which are essentially adrenergic agonists, such as beta 1 that we just mentioned, dobutamine, norepinephrine, and so on. And then combined beta 1 and beta 2 agonists, such as epinephrine and isoproterenol. Um, then we, of course, did talk about dopamine in the previous slide. As far as surgical management of heart failure is concerned, we have surgical approaches to end stage heart failure. Now, these procedures continue to evolve. Although large randomized trials are unusual in this field, important steps have been made over the past 10 to 15 years as discussed on the slide. However, the use of any of these approaches remain highly individualized. In specific circumstances underlying heart failure, uh, patients may undergo coronary revascularization, which means re-establishing blood flow in the coronary arteries when the heart failure is triggered by chronic ischemia. or there is ischemic cardiomyopathy in the myocardium. Additional procedures listed here are largely out of scope of discussion. However, ventricular assist devices and cardiac transplantation are the two options that will be discussed in surgical approaches or surgery in cardiopulmonary conditions, as well as in the equipments lectures. So, to bring together some physical therapy concerns in heart failure. Physical therapy concerns are based on underlying context of the diagnosis in each patient. In the acute stage, usually seen in the hospital, there is generalized increase in exercise intolerance due to loss of cardiovascular reserve. When additional fluid retention and related increase in weight is included, it severely limits function. Additionally, this is the decompensated stage of heart failure and usually not conducive to begin a rehab program. We conduct evaluations and advise the physician or referring source to specific problems in the patient's function or discharge disposition. But we also advise them to wait for our definitive recommendations until after the patient is fully compensated by medications. In the chronic stage, we are typically dealing with patients not in the acute setting. They can be at home, so being seen by home health or in the clinic of a physical therapist. In these patients, the single most effective method of monitoring for possible decompensation of heart failure is to conduct daily weight measurements and keeping a log. Patients who are using inotropic drugs can demonstrate toxicity of the use of such drugs. Specifically, the toxicity of digitalis is well known. It causes GI symptoms of nausea, vomiting, diarrhea, which is kind of generalized symptoms. However, in the central nervous system, it affects it such that there can be drowsiness, intense fatigue, and visual disturbances, leading to altered mental status in some patients as well. Specific cardiac symptoms of digitalis toxicity include arrhythmias that can be dangerous enough to progress to death. Therefore, monitoring baseline and activity based vitals on patients who are on digitalis is a must. Peripheral vasoconstriction is a known complication of inotropic drug use. These vasoconstriction leads to cutoff of blood supply to the terminal digits and toes that lead to end arterial constriction. For further questions or discussions, please contact the instructor. Please provide comments and suggestions below. Please like and subscribe to this channel for additional lectures on topics of interest for the acute care and cardiopulmonary physical therapist.